Okay, let's get started because I got to move along pretty quick. All right. Diseases of the pericardium is what we're going to talk about next. I forgot that I didn't get to it last week. Okay, so I got to catch up and do this and then do the pulmonary embolus discussion, then we'll do vascular ones last, if I can get to it. Hopefully I will. Anyways, the diseases of the pericardium, when you look at it from simplified points of discussion, we're going to go into different pericardial diseases. We'll be able to understand and be able to treat cardiac tamponade, sort of understand constrictive pericarditis, and then be able to manage and treat these different kinds of pericardial diseases. And when you look at the pericardial anatomy, the actual heart itself is separated from the thoracic structures of the lungs and their other mediastinal structures by this very thick material called the pericardium. The pericardium is actually a sac that is covered by two layers. Okay, basically, you think about it, the pericardium, think of it as a ball, and then put your fist into the ball. As you push your fist into the ball, you actually develop the visceral layer, okay, which is right along the surface of the heart. Okay, this is the portion where the pericardial arteries are running on. Okay, that's what the pericardial arteries are actually part of the pericardial sac. Okay, the outer layer, which is what we normally look at as a pericardial sac when you're actually getting in there clinically, is actually a very thick layer. And the normal in-between distance is what we call the pericardial cavity. That pericardial cavity has a very small amount of fluid usually in it, around 25 cc's. And it acts like a lubricant. Okay? So this sac material basically keeps the heart from surrounding structures, gives it ability to rotate as well as to move with minimal amount of friction because of this extra layer in between. Again, what the pericardium is actually covers the heart is considered in two layers: the parietal pericardium, which attaches to the surrounding tissue, and it's a space for the pericardial sac fluid. And the visceral pericardium is what's attached directly to the heart, and for the coronary arteries are attached, which is also considered the epicardium. So the epicardium is considered a portion of the pericardial sac. When you look at the pericardial fluid, it's an ultrafiltrated plasma and does not coagulate, which is good. It's normally around 20 to 25 cc's. So when you enter into that area, when you see blood enter this area, normally that blood will not coagulate properly. Okay, so if you have effusions or things like that that are bloody, most of them won't clot as a consequence of this fluid, the way its properties are made out of. It does isolate the heart from the surrounding structures. It prevents adhesions. And normally the intrapericardial pressure follows the thoracic pressure, which is important, which means that if you're putting positive pressure ventilation on somebody, well, that's going to transfer into this pericardial sac and affect the heart as a consequence. What you see with different diseases of the pericardium is you see an accumulation of fluid in the pericardial sac. It's going to either an effusion or if it's very big effusion, it goes into what's called a tamponade. But a cardiac tamponade is an effusion, period. It's some kind of effusion. It's either bloody or transudate, but it is it's fluid around the heart, except it's to the point where the person is becoming symptomatic. It's an inflammatory process, can also be occurring of the pericardial wall, which we call pericarditis. It can either be acute or chronic. And there can be also significant consequences of the inflammatory process, which causes constriction of the heart, which means it's scarification around the heart, and you get a reduced ventricular compliance and a diastolic dysfunction that can take place on the heart itself. Now, if you look at the etiology of pericarditis and pericardial effusions, most of them are idiopathic. Some of them can be due to infectious causes such as bacteria, funguses, viruses, or HIV. Myocardial infarctions can also lead to an inflammatory process which causes pericardial effusions. Radiation can actually cause a total inflammatory response, which can cause significant pericardial effusions. Usually they're very gradual, so as a consequence they are large in volume. Postoperatively, after open heart surgery, those are usually bloody effusions, and they can go to tamponade pretty quickly. Chest trauma, such as blunt or sharp, can also cause the effusions to take place and cause tamponade. Malignancy is usually picked up when you actually draw the fluid out of the out of the pericardial fluid. Instead of being a serous, yellowy kind of fluid, that indicates effusion. It usually will look bloody. So if it looks a little bit serous, then that's more likely to be malignancy. And you can have primary mesothelioma or angiosarcoma. You can also have metastatic diseases can also affect and cause pericardial effusions. You also have the collagen vascular diseases like rheumatoid arthritis and lupus. Metabolic syndromes like uremia or hypothyroidism are also known to cause this issue. A lot of people forget about the uremia. So patients that are in end-stage renal disease and chronic renal failure are the ones that are uremic. Those are the patients you've got to be really watchful of developing a cardiac effusion that can be very large. The largest cardiac effusion I've ever seen was 670 cc's. It's a lot of fluid. And it was on a patient who had a chronic renal failure and had been developing it for over a year. And he had still no tamponade physiology. So some effusions, even though they can be very, very large, don't necessarily cause tamponade. When we put this patient under asleep and no problems, we never had an issue with him. Other people with just another 25 cc's, they already going into tamponade physiology. So in other words, just having 50 to 100 cc's can be more than enough to do tamponade physiology if your pericardium doesn't have enough time to dilate. Pharmacological agents can also cause inflammatory processes such as penicillin, phenytoin, procainamide, hydralazine, and doxorubicin especially that we don't want to worry about. That's one that's given in chemotherapy for a lot of things. One of the things that pathophysiology of effusions is a continuum. Basically, from effusion to tamponade, is basically depends on speed, okay, and depends on volume, okay. Depends on the time of onset, which means that effusions tend to be more gradual. So, as a consequence, they remain effusions. Versus rapid, they tend to develop into tamponade. It depends also on the volume. If the rapid, small volumes may cause cardiac tamponade. So even though it's a small volume can cause problems, a large volume can also cause problems after enough time. But usually what will happen is the heart will actually dilate, and not the heart itself, but the actual pericardium will dilate. This is your normal pericardium as shown on this x-ray, showing you that it's nice and small. This person has a little bit of degree of COPD. You can see how black his lungs are, and they're hyperinflated. So the heart looks fairly small in this picture. Now let's show you a picture of what a tamponade looks like, or a effusion. That's how big the heart can get. Okay? And this is just a giant bag of water now surrounding the heart. As you can imagine, the heart sounds will be significantly diminished by all this fluid around the heart. That's one of the pickups that's telling you that you got something going on. Well, how can tamponade occur? Well, you can get chest trauma, postoperative bleeding, perforation of the ventricle, usually that's pretty fast. Malignant disease and chronic renal failure can also cause tamponade. What tamponade will do is the blood will actually get, or whatever fluid it gets out in between the heart, and will start squeezing the heart and constricting it. Eventually, you don't get any blood flow returning to the heart. So in essence, this person has a fixed stroke volume. Their engine cannot increase its contractility. Okay, all thing it can do is increase heart rate. So people that have tamponade are completely fixed in their stroke volume and totally dependent on rate to stay alive. It's basically the pathophysiology of cardiac tamponade is an increase in fluid between the pericardium and the heart. You get external compression on the heart, which decreases your venous return. This leads to a decrease in left ventricular end diastolic volume and decrease in right ventricular end diastolic volume. Here's what's really important. The volume is dropping in the heart, but the intrapericardial pressure is increasing. Okay? So your right ventricular end diastolic pressure and your left ventricular end diastolic pressure are both increasing. You see a greater increase in the right because it's more compliant in comparison to the left. Okay, so the right heart gets impacted more by tamponade initially than the left. Okay, this, as a consequence, impedes left ventricular volume eventually too, because there's not enough cardiac output leaving the right. Okay, so these people always have what kind of lungs? They're dry. They're dry lungs. They're not in failure. Their lungs are completely nice and dry. So you don't hear crackles, you don't hear wheezing, you don't hear any of that. Okay, but if you look at their neck veins, they're just jumping out at you. It's one of the easiest central lines you'll ever put in. Okay? Eventually, what you get a reduction in stroke volume, your PA pressures and your aortic pressures narrow down. Eventually, it decreases both, but you see an increase in CVP and your PA occlusion pressure. And then eventually, you get a reduction in cardiac output. What you see is, due to cardiac tamponade, the sympathetic nervous system gets activated, inducing a tachycardia, which maintains heart rate, maintains cardiac output by increasing heart rate. It increases also systemic vascular resistance by afterload increases. Eventually, there's a reduction in blood pressure. That's right before the person is about to die. So if you start seeing a person getting hypotensive and really tachycardic, you're in big trouble with this kind of case. The best thing to do is, if you have that situation, is put a needle into their chest and drain them before they go any further. Putting them to sleep could cause their death very quickly, and I'll explain that in a minute. You may also develop myocardial ischemia because of the increased external pressure and increase in left ventricular end diastolic pressure. Decreases your coronary perfusion pressure, so it's a significant problem. What you're seeing with here, this is a normal, and the green line here shows a normal preload line. What you see in tamponade is the actual preload line is actually shifting upwards, okay? And what you'll see in this individual is that you'll see the shift from this black normal preload pressure over volume curve to all of a sudden now your preload curve shifts upwards to this new green line, and your SVR is increased, your outflow is increased because of the increased sympathetic response. So what you're seeing is this individual has a higher preload value, even though the volume is low. Okay, so this is kind of hard for people to understand. Volume is going down, but pressure is going up inside the heart. Okay, as a consequence, you get the increase in afterload. You get a decrease in stroke volume, and that stroke volume is very limited. And if heart rate continues to increase, what happens is the time spent to allow the ventricle to fill becomes limited, and stroke volume can become even more of an issue. Okay. This is what eventually happens. Now your stroke volume is to the point that's so low that your blood pressure begins to fall, and then that person becomes symptomatic and is about to die. Okay. But notice one thing: what's your preload? What's your LV-EDP done at this point? It's very, very high. Okay, but your left ventricular end diastolic volume has become critically low. It's almost to the point where you're at the emptying value, okay, which you're at the dead space. Yes, it has to. The body increases sympathetic tone like crazy. So it begins to squeeze you down, peripherally. So when you touch these people's hands, you're ice cold. That's usually a bad sign, too. No, it doesn't move at all. It stays fixed. There is no increase in contractility. You may try, but it doesn't do anything. There's nothing there to squeeze on. So that's pretty lethal if it does. So if it happens, it's over. The contractility is pretty much staying fixed because of the increased sympathetic tone. It's increasing inotropy, but it's not really, it can't increase because it's got no volume to increase it to. So it tries to squeeze harder, but it's just not, it's got nowhere to go. There's not a volume. Tamponade, how you diagnose it, usually the person is dyspneic, not because they're wet lungs, because they don't have any blood flow to their lungs. Okay? So they become hypoxic, and they also develop increasing workload of breathing. Peripheral vasoconstriction is pretty impressive, that they will actually lose pulse oximetry, so your hands are usually ice cold. You get tachycardia, hypotension, and you have distant heart sounds, which are muffled due to the fluid around the heart. This is an echo showing you the actual heart, and this is the pericardium. You can see how large of a effusion this one is. Pretty significant. Okay. What you see in these patients is this is a normal waveform. This person has a PA waveform with a PA occlusion pressure underneath it where you don't normally see it. So when you occlude it, you get to see this. Now what happens in cardiac tamponade, here's what will happen, is the heart rate begins to increase, which limits your volume returning, but your pressures begin to increase. Your PA pressures are not really changing just yet here, but what's happening is the pressure is beginning to develop and increase in your PA occlusion pressure. And you can see the actual diastolic difference from your PA pressure and your PA occlusion pressure are becoming very clearly closer to each other. Okay? What will happen is it continues to progress. If it continues to progress, I think I got a picture of it later on. So cardiac tamponade, you get sympathetic stimulation, you get an elevated venous pressure, which is very evident on your external jugular vein. You also get what's called pulsus paradoxicus, okay, which is sometimes absent in patients that have ASD or left ventricular dysfunction, but it's seen in cardiac tamponade, tension pneumothorax, or COPD. What you normally should see on normal inspiration is that the person's pulse wave should diminish a little bit, okay, or stay fairly constant. But what you see in these individuals is that you will see their actual pulse wave actually increases on inspiration. The inspiratory effort actually helps eject more blood out of the ventricle, and you get a greater pulse wave during inspiration, which is not normal. Okay? The other thing you'll see is a Kussmaul's venous sign, which is JVD during inspiration. You get a prominent, sorry, it didn't show up. I don't know why it didn't. Okay. I had it in here. Anyways, you get a prominent X descent and a Y descent. You get the equalization of the atrial filling pressures. Okay, that's what I was talking about, in pulmonary artery and diastolic pressures. So here's what you will see here is on EKG, you get changes of QRS becomes diminished from the fluid around it, and you also get what's called an electrical alterans, where the QRS is actually changing in height. You see how the EKG is showing QRS changes in height. The reason it's doing this is it's actually changing and rotating an axis, and you're seeing an alteration in the actual Q wave height. It's really the best diagnosis by tamponade by echo. Treatment is give them fluids and temporarily, give them a lot of fluids, administer catecholamines to support the blood pressure, and then correct the metabolic acidosis if it's severe. Definitive is to do a percutaneous pericardicentesis till the surgeon gets there, which is you can do a subxiphoid or subcostal approach, or the next definitive procedure is, of course, a pericardiotomy, which is what the surgeon's going to do. Management is very important. How do you put these people to sleep? If you intubate them and you begin to ventilate them big breaths, you'll kill the patient very quickly. So one of the things that you want to do is when you induce these patients is maintain peripheral, you don't cause peripheral vasodilation, don't cause any more myocardial depression, and don't decrease the venous return any more you can do. So, and that's what general anesthesia will do every time. And positive pressure will also induce a worsening hypotension and cardiac arrest, because you actually squeeze the heart and cause it to heart completely collapse. So the correct treatment is first to do a pericardicentesis on this patient if they're that unstable. Induction usually is giving succinylcholine, ketamine, because it increases sympathetic response. And then you limit your positive pressure once you get them intubated. This is one of the things that we just want to puppy breathe for them and make sure that you've got the tube in the right hole, of course, and then giving a little benzodiazepines doesn't hurt. Maintenance, usually you can give 50% nitrous without any problem. Pavilon to increase heart rate, and fentanyl when combined should be no problem. And monitoring them with central line and A line is pretty important. You never put these people to sleep without an A line in place. Now let's go on to the next one, and we'll go into coexisting and talk to more detail later on about this disease process. We'll come back to it. So, acute pericarditis is an acute inflammatory process. What you see with this disease process is that you get this mucinous material that develops from an acute inflammatory response. You get ST segment changes in all the leads. It looks like a massive MI, but this is acute pericarditis. You get ST segment elevation in all leads. Okay? The cause of acute pericarditis could be infectious, idiopathic, or post-infarction, myocardial infarction called Dressler syndrome. Also, systemic diseases such as rheumatoid, lupus, or scleroderma will induce acute pericarditis. You can also get acute pericarditis from post-traumatic injury, metastatic disease, chronic renal failure, drugs, or radiation, just like those from other forms of tamponade. Acute pericarditis can go into tamponade, but it's a little bit more rare. Diagnosis is usually the person is having severe chest pain. It's exaggerated when the person takes in a breath, and also by putting the person in supine position, it hurts worse. It can radiate to the abdomen, and they usually get low-grade fevers and tachycardia. What they usually will get is a friction rub. You actually hear it on your pulse, on your actual stethoscope. You actually hear the actual rubbing of the pericardial sac. Pretty impressive. I've heard it. Once you hear it one time, you'll never forget it. It literally sounds like two people, like you're putting your two hands together and rubbing together. ST segments are concave elevations on all leads. That's pretty pathognomonic as well. You can also get the pericardial effusion from the acute pericarditis. And unfortunately, what that leads to is eventually into chronic constrictive pericarditis if it doesn't shut down. Most of the time, these are idiopathic. We don't know what initiated the event. It could be, again, radiation, chronic renal failure, rheumatoid arthritis, neoplasms of TB. It could be any of those. And what happens with this disease process is you can't have the heart has no ability to dilate. It becomes banded with scars, and it literally becomes restricted down. What you see is that in these individuals, you get a very rapid Y descent, but no X descent. The ventricle literally cannot fill properly after an atrial kick. So you get sort of in a bad situation, and now the heart won't take any more volume. The problem with constrictive pericarditis is that even though you repair the problem, it doesn't go away. You can actually go in there and fix the problem by doing a removal of the pericardium, but a lot of times these people take 6 to 8 weeks before they see the inflammatory process really shut down. And then you can get some resolution. But until then, that person's going to be sick for a long time in the ICU. But again, it's a banding effect around the heart. The right ventricle is affected mostly. It causes venous congestion, hepatosplenomegaly, and ascites. It eventually causes cardiac equalization pressures, just like a tamponade does. And the most common cause of death, believe it or not, is from atrial arrhythmia. These people have very important for them. If you're banded, if your ventricle is completely constricted down, what's really going to be important to keep filling it? The atrial kick. Okay? So when you lose the atrial kick from atrial fib or atrial flutter, then you lose 40% of your filling volume, and the person goes into asystole or goes into a bad arrhythmia. So it's critical to keep these people under sinus rhythm. This is one of the few cases where we've actually had to do cardioversions in the operating room, where somebody went from this into normal sinus rhythm into atrial fib during the case, and their blood pressure went from 110 to 60. Okay, so we actually cardioverted and got them back to a normal sinus rhythm, and also the pressure came back up to 100. It was like a miracle. Pretty impressive when it does happen. It goes wrong really, really quick. Treatment is surgical removal of the pericardium, and like I said before, surgeons are really not happy about doing this procedure because it's and literally they're actually taking a scalpel to the heart and scraping away the pericardium off, so it's not easy. And it's also right next to the coronary vessels when they're doing it. They can actually hit one of those. Bad things can happen. So it takes meticulous dissection, and it's usually 4 or 5 hours of meticulous dissection. And the bad thing about it is when you're finished with the case is really no improvement, at least not for several weeks. Okay. Yep. Yep. Most people don't know that.